Thank you for joining the Ohio chapter of the American Academy of Pediatrics for our Lead-Free Ohio training session today. It is March 6th, 2025, and today's session is titled Considerations for Refugee and Immigrant Patients in Pediatric Lead Poisoning Prevention. Thank you to our funder, the Ohio Department of Health, for funding this education session and supporting the health and wellness of children in Ohio. Thank you to the Ohio Academy of Family Physicians for sharing this education with their membership. The American Academy of Family Physicians, AAFP, has reviewed considerations for refugee and immigrant patients in lead poisoning prevention in children and deemed it acceptable for up to one live AAFP prescribed credit. The term of approval is from March 6, 2025 to March 6, 2025. Physicians should claim only the credit commensurate with the extent of their participation in the activity. AAFP prescribed credit is accepted by the American Medical Association, AMA, as equivalent to AMA Physicians Recognition Award, PRA, Category 1 credits toward the AMA PRA. When applying for the AMA PRA, prescribed credit earned must be reported as prescribed, not Category 1. Just a few administrative details. Please keep your camera and audio off for the duration of the session. If you have questions or comments while our speakers are presenting, please use the chat feature. We will have time for a Q&A at the end of the session, during which you can put your questions in the chat or raise your hand and ask them aloud. We intend for this session to be conversational and discussion-based education. As I mentioned earlier, please feel free to raise your hand or share in the chat throughout the presentation. We welcome your professional insight, especially as we explore cases in the second half of the webinar. The planners, faculty, and others in control of the content, both individually and as a group, have no relevant financial relationships with ineligible companies. We have considered the Ohio AAP Speaker Toolkit standards in preparing this presentation. It is our intent to foster respect, belonging, support, and accountability with the patients we serve. If you have any questions or concerns, please contact Dr. Kelsey Logan at the email on the slide. With that, today's session will be presented by Dr. Rupa Thakur and Dr. Nick Newman. Rupa Thakur, MD, FAP, is a practicing pediatrician at Cleveland Clinic Independence Family Health Center. She's board certified in general pediatrics. She earned her medical degree from the Ohio State University College of Medicine in Columbus, Ohio, and completed her postgraduate training at Cleveland Clinic Children's in Cleveland, Ohio. Dr. Thakur's interests include resident education and healthcare advocacy. She currently serves as the Associate Program Director of Cleveland Clinic Children's Pediatric Residency Program, overseeing the primary care experiences of our trainees. She also serves as Medical Director of School-Based Health Clinics and Medical Director of Youth Strategies for Cleveland Clinic Community Health Partnerships. A lifelong resident of Ohio, she's committed to improving living conditions for our community's children and serves as the medical director of the Lead-Free Ohio program, operated by the Ohio chapter of the American Academy of Pediatrics. Dr. Nicholas Newman is the medical director of the Pediatric Environmental Health and Lead Clinic at Cincinnati Children's Hospital. He earned his medical degree from Kirksville College of Osteopathic Medicine and completed his residency at Children's Hospital of Michigan. He earned his Master of Science from the University of Cincinnati and completed a fellowship in occupational and environmental medicine. He's board certified in pediatrics and preventive medicine. If I could just remind everybody in the call, if you could please turn off your camera and mute your audio. Thank you. In addition to his clinical responsibilities, Dr. Newman is the co-director of the Community Engagement Core through the University of Cincinnati Center for Environmental Genetics, funded by the National Institutes of Health. Dr. Newman also serves as the United States EPA Pediatric Environmental Health Specialty Unit for the Midwest region. Thank you so much, Dr. Thakur and Dr. Newman, for being with us today, and I will turn it over to you.
Thank you, Suhavi. Okay, so after today's session, you'll have reviewed screening guidelines for refugee health and the differences between lead screening and testing in the US in comparison to other nations. You will understand the application of motivational interviewing and cultural humility in immigrant and refugee patient encounters, and you'll become familiar with the Ohio AAP's Childhood Lead Poisoning Prevention Toolkit. Next slide, please. So we'll start by level setting a little bit. What is lead? Lead is a malleable, corrosion-resistant metal that appears in multiple forms, but it's lead plus 2 that our bodies can absorb. And we've been using lead for various purposes for about 8,000 years. As far as we know, the first report of lead toxicity came from the ancient Greeks approximately 2,200 years ago, and the CDC refers to lead as the first known pollutant. Acute toxicity has been recognized throughout this time, but it was only recently that the risk of subacute exposure has been recognized, and it's clear that lead exposure has been increasing over time. Next slide, please. We know that lead is a poison that impacts nearly every organ system, but the effects that we're most concerned about, especially in children, are on the neurologic system. With the primary target being the brain, we can see a decrease of around 5 IQ points for every 10 micrograms per deciliter of lead in the blood. There's data to suggest that up to 25% of ADHD cases may be attributed to lead exposure, and that antisocial and criminal behaviors may also be linked to lead exposure. We know that there's no safe level of lead in the body, but the CDC uses a blood lead reference value of 3.5 micrograms per deciliter to identify children who have higher levels of lead in their blood. The reference value used to be 5 until 2021, which is why some of the studies that we'll talk about today use 5 as their cutoff to define an elevated blood level, but the current level is 3.5. We also know that the effects of lead poisoning are not reversible. And if a child has iron deficiency, the effects of that lead poisoning may be more severe. Next slide, please. So in addition to the decreased IQ and behavioral concerns that I mentioned a moment ago, a child with lead poisoning may also experience poor academic performance and achievement, increased risk of delinquency and incarceration. Prenatal exposure to lead also has an increased risk of premature birth, which comes with a myriad of other chronic health concerns, as we all know. Next slide, please. The Cincinnati lead study found that lead was significantly associated with loss of cortical gray matter, particularly in the ventrolateral prefrontal cortex and anterior cingulate cortex. So these areas of the brain are primarily associated with judgment, impulse control, emotional regulation, and what psychologists call executive functions. So these effects on the brain likely explain the significant neurologic and behavioral effects that we see in people with childhood lead poisoning. Next slide, please. Children less than 6 years old are at higher risk of lead exposure because their bodies and brains are rapidly developing and growing, and therefore more susceptible to the effects of lead poisoning. Young children around 1 and 2 years of age also tend to put their hands or other objects into their mouths more, a lot of that hand-to-mouth behavior, and they're playing on the floor where lead dust settles. And so when they get that lead dust on their hands or onto objects and then they put it in their mouth, that results in ingestion of lead dust at a higher rate than older kids might. Children from low-income households and those who live in housing built before 1978 are at the greatest risk of lead exposure. Houses built before lead paint was banned in 1978, including those houses in low-income areas, are more likely to contain lead within the environment. We know that low-income housing disproportionately affects children of color, so Black and brown children are also at higher risk of lead poisoning. And finally, immigrant and refugee children from less developed countries are at higher risk of being exposed to lead for a variety of reasons that we'll dive into today. Next slide, please. Now, that last group is really critical and often overlooked. So we'll start with some basic statistics to understand why we need to keep immigrant and refugee patients on our radar. So at this time, 14.3% of US residents are foreign born, most coming from Mexico, India, China, and the Philippines. In 2024, the US admitted over 100,000 refugees, the highest number in 3 decades, and the UN High Commissioner for Refugees estimates that almost 3 million people will need resettlement this year. And 1 in 4 children in the US are children in immigrant families, meaning that they were either foreign born or have a parent who's foreign born. Next slide, please. So this is important to recognize because children in immigrant families have some unique challenges or threats. These kids are less likely to have access to a medical home and public benefits, and therefore may be suffering the effects of poverty, food insecurity, housing instability, and other social drivers more acutely. Many families face threat of deportation or forced separations, which can worsen their access to those basic needs. They may not have had adequate health care in their country of origin, including screenings and immunizations that we might take for granted. So they may have some undiagnosed or unaddressed chronic health conditions. These children are at an increased risk of anxiety, depression, sleep disturbance, disordered eating. Some may have experienced significant traumas in their short lives prior to landing in your office. So being aware of these risks is really critical to providing the care that these children need. Next slide, please. So I mentioned a moment ago that around 3 million refugees are expected to need resettlement this year, but the U.S. may not be where most of them land. On January 20th, the president signed an executive order suspending U.S. refugee admissions program until those efforts align with the interests of the U.S., which will be reevaluated every 90 days. The Secretary of State and Secretary of Homeland Security may jointly determine to admit refugees on a case-by-case basis, but it's unclear what volume of refugee entry we might expect through that process. Regardless, I'm not bringing this up to discuss whether we agree with this policy or how we feel about it. We're here because without support for dedicated domestic health screening programs, general pediatricians will need to understand how to care for those immigrants and refugee children optimally when they show up in our offices, and to understand the significant risks of lead exposure in that population. I think I have a friend and colleague here with us today, Dr. Stephanie Dooley from Neighborhood Family Practice up here in the Cleveland area. NFP is a primary healthcare provider for the 3 refugee resettlement agencies in Greater Cleveland. So Dr. Dooley is an expert in refugee care. And so Stephanie, if you're on the line, please feel free to chime in as I go through the next few slides if there are points to clarify or expand on. Next slide, please. So the U.S. Refugee Resettlement Program is the formal process by which a refugee comes to the United States and is resettled in communities by local agencies. So before arrival in the U.S., refugees receive pre-departure medical and mental health exams, usually by the International Organization for Migration, or IOM. These exams are conducted by panel physicians appointed by the U.S. Embassy or consulate and include a thorough medical history, vaccinations, and pre-departure treatment for any infectious diseases. The IOM then securely transmits that health information from the overseas medical examination to the CDC, who then transmits that information to the receiving U.S. healthcare provider, of which NFP, Dr. Dooley, are one. Next slide, please. So upon arrival in the U.S., refugees generally receive their first set of post-arrival laboratory screenings and vaccinations at a health department, community health center, or an academically affiliated clinic within their first 30 to 90 days in the U.S. Records from that pre-departure exam and any other medical records that they have should be requested, if not immediately available, to try to avoid repeat laboratory tests and vaccines. No need to reinvent the wheel, right? So before they actually have their visit, it's a good idea to try to request what we can. And then during that initial screening appointment, providers should review overseas medical documents, address the refugees' immediate health concerns and priority needs based on their current symptoms, as well as obtain a detailed history, including documentation of, your standard past medical history, medications, allergies, social and family history. And additionally, we should include aspects unique to refugees, such as history of toxic environmental exposures, a detailed dietary history, travel geographic history. In addition to that, some routine parts of the exam are blood pressure, vision, and hearing. We should conduct a thorough head-to-toe physical exam and assess for mental health concerns using a validated tool, such as the RHS-15 questionnaire. Of note, refugee children are typically able to receive Medicaid and may have case managers who assist their families with finding health services, among some other supports. So your patient will hopefully have access to some of those wraparound services through their case manager. Next slide, please. Now, some important considerations for welcoming immigrant and refugee patients into your practice and getting started on the right foot. We'll start with that. The domestic medical screening is likely a refugee's first routine medical encounter within the US healthcare system. So it's really an opportunity to begin establishing a relationship with um, a healthcare provider based on trust. So, in an ideal world, all of your clinical staff should complete cultural humility and implicit bias training. This would include the medical team as well as your front desk staff and any others who might interact with your families. Signage in the office should include common languages in your community. So, if you have, for example, a large Ukrainian population or Somali population near you, including their languages on your signage. It's critical to use qualified medical interpreters for any patient with limited English proficiency. So, ensuring you have access to an interpreter with the patient's preferred language at the time of the visit will be crucial. If they can be there in person with you, fantastic. If not, at least a telephone interpreter. Images and artwork in your clinical setting could reflect the population around you, including people of all colors, to make your patients feel welcome and seen. And if you have the resources, integrating social work, community health workers, financial counselors, and other wraparound services can help your probably overwhelmed and stressed families get better access to the services that they need. And then finally, setting clear expectations with the family. Introduce yourself and members of the care team. Clarify how the information gathered in this visit will be used. So, patients and their families should be assured that this is a confidential medical visit for their health, does not have any regulatory purposes, and will not affect their resettlement or visa status. The information that we obtain in these visits remains only in the medical record, which is not shared with government authorities, and they can choose not to answer a question at any time without experiencing any negative repercussions. However, there are some techniques to optimize their engagement and get those questions answered as best as we can. So, normalizing is one of those, saying things like, these are questions I ask all of my new patients, or framing. So, I'm asking these questions because it helps me understand how to better care for you, how to better care for your child, what services you might need, explaining why you're asking the question. So, those are two techniques that can help the parent and patient feel a little bit more comfortable. And for the physical exam, while the patient is still clothed, it's important to explain to the caregiver and the patient what the physical exam entails and how it's going to go forward. So many children from developing countries have never had a complete head to toe exam by a medical professional because most visits that they might have had to a healthcare setting might have been focused only on a specific presenting concern. So this might be the first time that a child is asked to undergo a full routine health maintenance visit, and likely their first time that they're undergoing an external genital exam. So if a patient or family is not comfortable with any part of the exam and has no specific concerns in that area, that portion of the exam can be deferred until the second visit, but should really only be considered an option if follow-up can be ensured. So as best as we can, try to upfront explain what's required of the exam to get them on board, to have that done at the first visit. Next slide, please. And as you move forward in your conversation with the patient and family, you may encounter some roadblocks or points where you feel like you're not on the same page. And this may result from differing cultural views on the cause of or meaning of an illness, different styles of communication, traditions, spirituality, etc. So there's actually a 2019 article in Pediatrics titled Providing Care for Children in Immigrant Families that recommends a nice cross-cultural practical framework for getting to the heart of these issues and moving forward together. So some of the questions you can utilize are, what do you believe is the cause of this problem? How does it affect your body and mind? What do you fear most about the condition, or what do you fear most about this treatment? So these are non-judgmental questions designed to help you understand your patient's perspective a little bit better so that you can then engage in some motivational interviewing to guide your conversation and get their buy-in for the treatment plan. So I can give you a very brief example. It has nothing to do with lead, but I had brand new patients who had immigrated from India and just had their first child. And this little baby was pretty severely jaundiced. So I was talking about Billy blankets and repeat lab work and a plan for readmission for phototherapy if the level was higher than whatever cutoff. And I finished talking, and the mom says, "But I don't understand how she got this. we didn't dress her in yellow when she was born. And I had no idea what she was talking about. I was really confused. So I backtracked quite a bit and I asked, well, what causes jaundice? Like tell me what you know about it. And she said that the area of India that she immigrated from had a custom that they don't dress their newborns in yellow because that would bring more yellow to the skin. So she had this understanding that the yellow color comes from the environment. So once I understood what her baseline knowledge was, I was able to have a much more fruitful conversation about what was actually happening with the baby and what our next steps would be going forward. So it seems like it's a kind of out of the box example, but I hope it just demonstrates how getting to the root of what the parent's understanding is can help a lot with moving forward. Next slide, please. Okay. So we'll bring this all back to lead now. What do we know about lead in immigrants and refugee populations? We know that certain refugee groups have rates of elevated blood lead levels over 40%. That's huge and truly a shame if we were to miss it. Major predictors of lead poisoning risk are age, country of origin, and country of last residence, with India, Afghanistan, Burma, and Nepal being probably highest risk. We know that lead exposure doesn't stop there. They're also at risk upon resettling in the US. And there was a study in Syracuse that found that 6.3% of children with an acceptable blood level on their initial screening had elevated levels on follow up, confirming lead exposure in their current environment as opposed to prior to arrival. Next slide, please. So in Ohio, data trends are similar, showing that children of resettled refugee families are 3.62 times as likely to have a blood lead level over 5 prevalence and over 6 times as likely to have blood lead level over 5 during study follow-up. Next slide, please. So where does lead screening fit into the domestic health medical exam? The guidelines recommend that a blood test looking for lead is conducted at the first visit on all children under 16 years of age, and those over 16 if there's a high risk or high index of suspicion, such as like a sibling with lead poisoning, for example, or if they have clinical signs or symptoms of lead exposure. And then a follow-up blood test at 3 to 6 months is recommended for all children under 6, regardless of what their initial screening result was. Children 7 to 16 with a history of elevated blood lead level, of course, should be repeated in accordance with our standard medical management guidelines. And those with exposed household contacts or environmental exposure risk factors should also undergo repeat testing at that time. And then in addition, all pregnant and lactating people should undergo an initial lead test at that first visit. And if that test result is elevated, then have the repeat testing in 3 to 6 months. Next slide, please. So we'll zoom out for a moment and just think about lead poisoning worldwide. So how are these patients exposed in their countries of origin, and how big of a problem is this really? The UNICEF estimates that a third of children worldwide, so about 800 million in all, have lead levels over 5. Some common sources of lead exposure across the globe are battery recycling plants, open air smelters, lead glazed pottery, lead containing spices, paint, and e-waste recycling. Next slide, please. So if we look at estimates based on best available data, we can see mean blood lead levels in countries like Pakistan, Palestine, Nigeria, and Nepal are among the highest, with the greatest prevalences of lead poisoning among their children as well. And one caveat here is that the age of children was defined differently in different countries. So we're not always comparing apples to apples, but you can see that this is a significant problem globally. Next slide, please. The two most detrimental environmental exposures are leaded gasoline and paint. So the good news here is that leaded gasoline has been phased out as of 2021. The last few countries to legally ban leaded gas for vehicles are listed here. And you'll see some pretty astonishing overlap with our list of countries of origin for refugees, including Afghanistan, Myanmar, North Korea, and Yemen. And we should be aware that the lead from previous years can still remain in the environment, so particularly in soil for a long time, making it a persistent environmental pollutant. We find this in urban areas or along major roadways where leaded gasoline was widely used. So while it is great news that leaded gasoline has been phased out, we can definitely celebrate that, but still something to be cognizant that it was likely still in their environment. And we're waiting for that success story for leaded paint. There are still 109 countries, largely in sub Saharan Africa, Central Asia, and the Middle East, that have not yet banned lead based paint. Next slide, please. So this map shows legal bans on lead paint as of January 2024. Countries in blue have legislation banning the use of lead paint, while those in yellow do not. So you can see that clustering in sub Saharan Africa, Central Asia, and the Middle East a little bit more clearly here. Next slide, please. So, lead based paint has a similar story to leaded gasoline in terms of how persistent of an issue it can be even after it's banned. In the US, lead based paint was banned in 1978. In Ohio, the vast majority of our housing stock, both urban and rural, was built during the lead paint era before 1978. So leaded paint is likely in our homes, in our patients' homes, and as the paint chips or deteriorates into dust as we open and close doors and windows, that lead-based paint poses a continual risk to our children. So if you'll hit next, Suhavi. Um, we know that about 80% of cases of lead poisoning in Ohio are attributed to lead-based paint for that reason. But when we have our immigrant and refugee population in mind, we also need to consider all of these other potential sources of lead that may present significant exposure risks. And to talk about how we do that effectively, I'll pass the mic to Dr. Newman.
If I can figure out how to unmute and turn my camera back on. Yeah, thank you very much. So I'd like to talk a little bit about like approaching this like kind of from a case by case perspective, because I think that helps to cement some of the ideas. And you know, I know like during my pediatric training, I learned more of this as an occupational environmental medicine fellow. Um, was taking an environmental health history, and it can be extremely involved. You know, you could have hundreds of questions, but ultimately there's a few key concepts. And so a colleague of mine years ago came up with this kind of mnemonic, but the idea is like you ask about a child's activities, like, you know, what do they do, where do they go, what about the community, are there any known hazards in the community, um, about the house, because people spend a lot of time at home, and you know, its age, its condition, uh, things used in the house. And mind you, like a lot of people, if they're renting, may have no idea about the age of the house at all. People who own the property generally do. Hobbies, you know, so um, because I run kind of a little like specialty, like niche clinic, um, I've found out all kinds of hobbies that people participate in: grinding stuff, melting stuff down, like all kinds of things. And so just finding out if anyone has a hobby that has anything to do with metal is a good starting point. And then what do people do for work? You know, if it's an adolescent you're talking about, it may be them. But you know, for younger kids, it's generally going to be caregivers or other adults in the home. And you know, a couple of occupations come to mind that are high risk for lead, like one being people working construction, and then the other, people who are doing anything else, either with paint or with batteries. And because of where, you know, we are located in the Midwest, there are a lot of automobile related plants, you know, some of which, you know, there are battery plants in Ohio and in my case Kentucky, um, that are making lead acid batteries. And then what kind of oral behaviors does the child have? So that's just like a basic approach, and then I kind of build off stuff from there. And I'll use this kind of in the examples as we go ahead. Okay, next slide, please. So our first case is a young girl who presents with a blood lead level of 39, which is quite high, right? And she's been having constipation on and off since starting solid foods. And she was born in the US, but her family came from Mexico about 10 years ago. And her previous lead level was 10. and the home was found to have lead hazards, and those were abated last year. So these cases are not exactly like ones from my clinic, but I've kind of adapted like multiple like kids so that we can come across, with the points. So next slide, please. So we're just going to step through the activities, and I guess I'll just say next as we want to go. So next. So what does she do? She stays home with mom and grandma, who lives in Mexico, who's been visiting for the holidays. Next. Next. So they live in a residential area, but it's mostly like pre-1950 housing. So there's a lot of, potential exposure for lead, mostly from soil, because all those old houses kind of share the lead dust back and forth. Next. So the house itself, they had the lead hazards abated, but grandma had given her a remedy for el empaco. And you're like, oh, okay, well, that's interesting. Next slide. Sorry, next. Yeah. No hobbies that contribute. Next. And mom stays home and dad works at a factory. And you're like, oh, okay, maybe that's it. But he works at a food factory. So they're making ketchup and tomato sauce. Next slide. I'm sorry, next thing. And then occasionally she puts a toy in her mouth. So next. So what's el empaco? And I'll tell you, like, I know like poquito of Spanish that I learned in Duolingo when I was trying to work there in Guatemala about 6 years ago. So please forgive me. But this is what we would call like kind of a cultural illness. Like there's not like any specific like diagnostic, like medical diagnosis here, but it's basically related to some kind of intestinal blockage. And it's described in cultures all throughout Mexico, Central America, and South America. And the treatment is everything from something supportive, or maybe some like mild herbs, to Azarcan and Greta. And Azarcan and Greta are basically made out of lead. And so both either lead oxide or lead tetroxide. Next. So, a lot of times, like, people are trying to treat something like constipation and they're like, oh, there's some blockage. And so we need to use our special medicine. And grandma just happened to bring some with her. So as you're talking to families about this, you really have to get on what page they're on and then figure out how you can get them to your page, and when I see patients like this, my thought is like, okay, well, the goal in mind is to stop using the Greta, right? So, which means that we actually have to address like what the clinical complaint is. And I put this Bristol stool chart there just so you could think about like, what do we call, what's diarrhea versus what's constipation. And really to try to figure out what they're trying to cure, because this cultural illness can have elements of both, right? Because you might be constipated and then you have overflow incontinence or et cetera. And then try to provide like a treatment plan to the family, like after you've talked through like what you think it is and what you might recommend. And also indicate like the dangers of you continuing to use this, this home remedy. Next slide. So heavy metals are used in a lot of traditional remedies, and because people have recognized special qualities of various metals for years. And the other trick in here is that lead can cause constipation. So like you can actually make the problem worse. And so you'll be getting more of it. And I would say like you want to look out for people using red or orange powders in general. But, we also have to think that, all through the United States, for instance, before we had antibiotics, arsenic and mercury were used as antimicrobials, right? So like, it's not crazy to use these metals for things. It's just that there's better stuff out there, right? That are less toxic. And then because I wanted to talk about, there are other like ethnic and cultural communities that use different uh, uh, other compounds containing lead. And, so the Hmong community uses Peilula, which is a red powder, and that's given like for rashes and fevers. There's several items used by the Asian Indian community sometimes. Gripe water, I think, is the one that I've run into the most. And then although not only in Arab American communities, but kohl and surma, like this is used as eye makeup, but also it's considered like auspicious and as a disinfectant. Next slide. So we'll go on to the second case. So this is of a 4-year-old with a blood level of 12 who moved from India about 6 months ago, and dad works for a local aerospace company. He's a vegetarian and he mostly eats at home. And the health department did a lead risk assessment. Next slide. Which in Ohio they will do if the lead level is over 10. I apologize, when I put the timings in for this, I didn't realize how awkward this would be. So what does this child do? Well, stays home with mom, but it goes to preschool like 3 days a week. Next. They live in a newer subdivision, built in 2015, so much less likely to have any lead nearby. Next. The home, when they moved from India, they brought spices and pots and pans with them because they already had some stuff and they liked it, right? So that only makes sense. I mean, if I moved somewhere, I would take my stuff too, right? Next. Mom, the only hobby she has is to paint with watercolors. They generally don't have any lead, although there is some concern about some of the other art paints can contain lead and chromium and a bunch of other items, so they should be kept away from children. Next. Yeah, mom stays home with their child, and dad works as a software engineer. So no real exposures there, right? And then occasionally he puts a toy in his mouth, which is not that uncommon, right? So next slide. So the other thing we have to think about, they recently moved from India, right? So about 50% of children in India are estimated to have a blood level over 5. And lead paint and gasoline were phased out relatively recently. There's a lot of construction going on in India right now because there's a lot of economic growth and a lot of changes going on. On top of that, spices and seasonings have been found to have lead in them for a long time. Maybe the exposure occurred in India and it's coming down, right? That's a possibility, right? Next. So the Ohio Department of Health did a lead risk assessment, and they tested the spices, turmeric, rice, pepper powder, some dal, and they were all negative for lead. But the aluminum cooking pot was positive for lead. And Columbus, I don't know if there's anyone on from Columbus Public Health, but thank you very much for the handout you sent me a few weeks ago. I incorporated a couple of pictures that they had used in their handout because these are very ordinary looking pots. There's nothing here that would make you think that there was anything about them. It turns out that some of these pots are made from just like poor quality, like scrap metal that happens to be also contain lead. And so if it says, leachable lead, and the way this is done is a measured amount of acetic acid is put on the pot, and then that is left for a certain period of time, and then it's decanted off, and then that's sent to the lab because lead tends to dissolve into acid solution. So that's why they say leachable. But the one on the left, like in the middle on the left, that is actually a pot from Afghanistan. And there's a whole number of them. If you go on the FDA website, there's the Consumer Product Safety Commission website. There's a whole bunch of stuff about those particular ones. So next slide, please. So lead can be found in all kinds of cookware, mugs, plates. Some glazes contain lead, particularly Mexican, Tunisian, or Moroccan. Once again, these aluminum pots, India, China, Afghanistan. And typically they look fine. Like there's nothing that looks wrong with them, but the acid and the heat like leach the lead out. And so if you're cooking like tomatoes or something that's, acidic food, that's gonna pull more and more of the lead out into solution. Next slide. All right, so case 3. So this is a 5-year-old female who emigrated from Afghanistan about 6 months ago. Her initial lead level was 9, and it's been gradually increasing. Now it's 14, and her hemoglobin is a bit low, and her ferritin is quite low. And that makes sense because we know, that's fine, you can keep us on the next slide, Suhabi. Because we know that iron deficiency is the most common micronutrient deficiency worldwide. And children who are coming under like difficult conditions may not have been getting the best food possible like prior. So we'll start with activities. So she stays home with her mom and attends kindergarten 5 days a week. So you're mostly at home, but then goes to school. Next. They live in an older, like post-industrial, first-ring suburb of Cincinnati. So the houses are like, 100 years old or more. Next. And they live in a house that's over 100 years old. The family brought nothing with them from Afghanistan because they basically barely the clothes on their backs. And next. No hobbies, no time for hobbies, right? Mom stays home. Dad works as a delivery driver. He had been an interpreter for the U.S. military during the Afghanistan war, so he was able to resettle his family here. Next. And she's a nail biter. Not surprising, right? There's a lot of kind of anxiety-related behaviors in kids who have been like forced to relocate or come from difficult circumstances. Next slide. So other considerations, the leaded gasoline, Afghanistan was one of the last countries to phase out leaded gasoline. The very last country was Algeria, I think. But the U.S. banned leaded gasoline in '96, but it's still using aviation gas. So that's actually becoming a significant source of exposure now. But that leaded gasoline resulted in contamination of like all the soil, particularly in urban areas, and the oceans, and like just about everything else. And prior to the ban, the average blood level of U.S. children was 16. So back in the 70s, like that was the average blood level. The family was resettled into pre-1950 housing, but there's no spices or other items. And I will often talk to people and see like where are you buying stuff? Are you getting stuff from the local like Indian store, or are you getting stuff from online or whatever? Because some of that is a little questionable. Next. So they did do a lead risk assessment at the house because the lead level was over 10. So there was deteriorating lead paint found like in a lot of different places, and the floor dust loading was quite high. I mean, the current like hazard level is defined as anything that's detectable. And she likes to play in the yard, and it turns out that the lead in the soil was also extremely high for a play area. And they also had some spices that they were ordering, but they were negative for lead. Next. So probably the exposure started back in Afghanistan, right? But then there was additional exposure that occurred in Ohio. And they lived in older housing with deteriorating lead paint, and the and it's known that if you're lower income, there's a higher risk for lead exposure, even in a neighborhood, two neighborhoods with the same age houses. The lower income neighborhood, there's more likely to be housing in poor condition. And many refugees and resettled families are in kind of precarious financial situations and therefore may end up in poor quality housing. I remember we had a series of kids in our clinic here, and our social worker actually met with one of the resettlement agencies and talked to them about this problem. And they then became a lot more aware of where, aware of like where the houses were that would be problematic. And so they worked hard to prevent families from getting resettled into houses that had lead hazards, which was really terrific. Next slide. So the fourth case, this is a 2-year-old girl of Nepalese parents with a blood level of 8. Now, if you know the history a little bit, the parents are ethnically Bhutanese, but they spent like almost 2 decades in a refugee camp until they were able to move to the U.S. The child was born in Ohio and has had no recent travel outside of Ohio. Next. So we'll go through the history. Yes, so she stays home with mom and attends temple with family once a week. That's about all she does. Next. They live in a residential area. There's no industry nearby, but the houses are of like various ages. Like, some of them were built like just, during World War II, and there's a fair amount of like post-World War II housing as well. Next. Their house was built in 1960, and the family buys spices and some prepared foods from an Indian grocery. Next. No hobbies. Next. And mom stays home, but dad installs insulation in houses. No demolition or anything. And oral behaviors is just like kind of age appropriate, like hands and toys. Next slide. So since the lead level was under 10, there was no lead risk assessment done. So you're like, oh, well, how are we going to figure this out? And there's not a lot of good answers here. You could think about water, even with the Flint water crisis, basically there was an increase in the percentage of kids who had lead levels between 5 and 9, but really not much change in percentage of kids with higher levels than that. You could privately test the food and spices. The problem with that is like, well, you test this stuff that you have. Do you have to test everything that you ever buy? Is there a possibility to take home exposure? Probably, depending on what dad is doing. If it's just purely putting insulation in, probably not. But if he's doing any like some demolition or repairs to an older house, that's certainly possible. Paint chip testing is available through some health departments. The truth is, it's like the highest risk housing was probably built before 1960, so like probably low yield in this situation, but it can be done. You can get house dust testing done privately through some commercial labs, but the parents have to collect it. It has to be collected properly. And soil testing is available through some health departments and through commercial labs. It's usually not very expensive. And then there's also the S-CHIP lead poisoning prevention program through the state. There's kind of limited availability for kids with lower lead levels, but I include it for completeness. Next slide. So they opt to test the spice through the lab, and it turns out the turmeric is extremely high. There's not actually a standard for spices, but candy standards is set at 0.2 parts per million. So it's like really high. So how does how would it get into there? So this is turmeric, for those most people would know, but like because it's like very like in among like the health food types now. Um, so how does it get into spices? Well, the soil could be contaminated. It's a root, right? So if the soil is contaminated, you'll get it. It could be adulterated with either lead oxide or lead tetroxide because that gives it a better color, and so the farmers can get a higher, better price for it. Sometimes, if it's dried like in another country, often it's dried near a roadway because it's hot and the sun, is beating down. But unfortunately, if you're near a roadway, the lead from the soil from the gasoline gets on it. Sometimes the grinders that are used to grind it up are used for multiple purposes and not just food. And then finally, lead is extremely dense, and so it might be added to the final product to increase weight. Next. So they ask, well, can we still bring our child to the temple to eat? All right, so like we have to address like some of these cultural specific concerns, right? First is to listen, right? And then think about like alternatives. Could you get, for yourself, could you get like certified lead-free turmeric? And then, in fact, there are brands of turmeric that are tested that way. The And like talk through it. I mean, I think we could think a little bit. Well, if you're only going once a week and she's only eating a little bit, like how much like risk is that really? Versus like being socially isolated and not connected. You know what I mean? So like we have to think about that. Also, like this is often an opportunity that I've seen this happen where families educate other people that in their community about it. And for a lot of families, they're completely unaware of the concept of lead poisoning because really only in the US do we routinely test children for lead. Like it's not tested in Western Europe, it's not tested anywhere else. So the US is kind of an outlier in that way, but we have probably the best grip on how many people are exposed to lead. Next slide. This is the very last case. This will be quick. So this is about a 2-year-old with a blood level of 9. Child was born in Ohio, but her parents are from Guatemala. Next slide. And here we go. So stays home with mom. Like, doesn't seem like everybody does. Next. They live in this apartment complex. It's all residential, no industry nearby. Next. And it was built in 1980. So like chances of lead in the house is low. Next. No hobbies. Next. And dad works in construction. He does like new construction and remodels. Next slide. And once again, hands and toys for oral behaviors, like very age appropriate. Next. So let's just talk a moment about take-home exposure. There's a lot of occupations that can be a source of lead in the home: construction, auto mechanics, aircraft mechanics, metal recycling, et cetera. This is not an inclusive list. Like there's lots and lots of occupations, but I put the ones at the top that are the most common that we would see. And in fact, construction is like really, really up there. Worker hygiene controls are important. So like leaving work at work, just changing the clothes and segregating and showering is a big help to prevent kids from getting exposed. And family vehicles can be contaminated with lead. And if you think about like big industries tend to have like, occupational safety and health, battery plants, et cetera. But like small mom and pop construction companies, they don't have that. And so people are working, wearing the same clothes back and forth, getting in the car, spreading the dust, And I've had some caregivers who like they can't figure out a way to deal with it, and they end up changing jobs because they can't find something that isn't going to bring home lead dust. Next slide. So once again, just looking back at these common sources of lead, and by far, like lead-based paint is it. But as you can see, like we've talked about several of these, and they're really not that uncommon, to tell you the truth. So food, soil, spices, medicines. Next slide. Yep, keep going. And I apologize. This is extremely small, but there is a QR code, but it just gives you an idea of like how many different things that you can find that have often found to have lead that people are using all the time. Next slide. And I don't know, Suhavi, do you want to talk about the toolkit or?
I can talk about it for
Okay,
a moment.
okay, thanks.
So yeah, there's a QR code here to our childhood lead prevention toolkit. Um, you can utilize this as a reference, almost to look up specific information about lead poisoning, including helpful definitions, signs and symptoms, long-term impact. In addition, we've heard from providers across the state that they struggle with some common pain points. So we've tried to provide specific resources to help address those issues. So for example, you'll find guidance in there on addressing parental or caregiver resistance to testing with potential responses that you could use for whatever reason that they might use, whatever excuse they might use to not want to do it. In the toolkit, we also share helpful tools and information to drive process or quality improvement in your practice around lead screening and testing. You can order rack cards from there to use in your practice. You can order our board books from there as well. So lots of great resources. Feel free to sign up. It's a free resource for you.
Thank you so much, Dr. Talker and Dr. Newman, for such a wonderful presentation. We'll now have a couple of minutes for questions. And you can either unmute and share them out loud or put them in the chat.
I'm curious if you can list some of those companies that clearly do not have lead in the spices, like you were saying, some of the turmerics, there are certain companies that pay attention to that.
Yeah, I'll be honest, the one that I'm like aware of, and I don't have any like connection to the company at all, other than I buy stuff from them. One's called American Turmeric, and they actually include a testing results with every batch they send you. It's a little like mom and pop company down in, I think in Georgia, maybe.
If you guys have any questions after the session, please feel free to email them to me. My email's on an upcoming slide, and I will be happy to share them with our presenters. Just a couple of administrative things I'd like to share before we wrap up today. Somebody did share in the chat that Consumer Reports has reported lead in spices for the person who asked that question earlier. So our upcoming education for the Lead Free Ohio program is going to be on March 19th of this year at noon, same time, same place on Zoom. We'll be hearing from Dr. Joel Davidson and Jared LeBron on the impact of food insecurity and quality on pediatric lead poisoning prevention. This QR code will take you to the registration page. I'll leave that up for a second. It'll also be in the follow-up email. I see another question in the chat if we could get the slides emailed. Yes, I will be sharing slides as soon as we're done here. If you haven't heard, the Ohio AAP has a wonderful practice coaching program for our lead prevention efforts. We have done this program in the past, and we're looking ahead to what may come in the future. It's a small change, big impact with minimal data reporting. So it's not quite quality improvement, but it's a step beyond education, and we found really great success in it. We're planning to kick off this program in late summer 2025, and it is designed to allow the provider to determine the practice's goals and changes. And it's really accustomed to you and what you're looking for. So if you scan this QR code, you'll be able to fill out our interest form. It's just a short form with your name and email and practice. This will also be in the follow-up. Leave that up for a second. I'd also like to share our Ohio AAP Spring Advocacy Day. This is free for members of the Ohio AAP. It will be on Thursday, April 10th at the Ohio State House, and we will be practicing advocacy in action. We'll be having an Advocacy 102 session, and then there will be optional legislative visits for those who decide to participate in them. You can scan this QR code here on the screen in the bottom right, or it will also be in the follow-up email. To claim your CME and MOC credit, please visit the Ohio AAP Outcomes page and complete the survey, even if you do not need credit. Check your email for a certificate within 10 days of completing the survey. If you have any questions or concerns, please email me at ssr@ohioaap.org. You can scan this QR code to go to our Outcomes page. It will also be included in the follow-up email. If you have any questions, feedback, or ideas for our education, my email is listed on the screen. You can also share any questions you may have for our two speakers today. You may also give me a phone call at the Ohio AAP office, and our office line is listed on the slide. Thank you so much for attending our session today, and thank you to Dr. Newman and Dr. Talker for being wonderful presenters, and I look forward to seeing you at a future Ohio AAP education session. Thank you.
Thank you.